Hi, everyone. My name is Misty Buskohl. I'm a family nurse practitioner who specializes in ear, nose, and throat problems, and I work at KSB Hospital in the ENT department. So I'm going to talk to you today about Eustachian tube dysfunction. So I have a lot of people who come into our clinic who have had a diagnosis of Eustachian tube dysfunction, or I'm giving them a diagnosis of Eustachian tube dysfunction, and they're just unclear of what Eustachian tube dysfunction is. So the location of Eustachian tubes are located between the pharynx, which is the space behind the nose and mouth, and to the middle ear. There's three main functions of Eustachian tubes. They are to ventilate the middle ear space, which equalizes the pressures, allows drainage of the middle ear secretions, and protects the middle ear from sound and the reflux of nasopharyngeal contents. So automatically and normally, without doing anything at all, our body actually equalizes the pressure inside the middle ear space every time we swallow, yawn. This usually happens about 84 times per hour while awake, and then less while sleeping. So etiologies, there's two when it comes to Eustachian tube dysfunction, one being patulous dysfunction. So with patulous dysfunction, it is when the Eustachian tube fails to close. So it generally does not cause any significant acute or chronic diseases of the ear, and it is less common. The most common would be obstructive dysfunction. This is when the Eustachian tube fails to open. So this is the one that's responsible for a large portion of otitis media and chronic ear diseases. This is a good picture here of patulous Eustachian tube dysfunction. So this is where an endoscopic camera is looking at the orifice or the opening of a Eustachian tube, and as you can see, it is open. Another picture of obstructive Eustachian tube dysfunction. So this is, again, the endoscopic camera taking a picture of the opening of a closed Eustachian tube. Hallmark symptoms include, but not limited to, so it'd be difficulty equalizing the pressure inside the ears during air travel or with altitude changes, history of otitis media, ear pain, sensation of oral fullness or ear pressure, hearing loss, tinnitus or tinnitus, reported ear popping or feeling plugged, and then autophony. That is when a person complains of hearing their own voice loudly. This actually is more common with the patulous Eustachian tube dysfunction, the one that stays open. In order for diagnosis of this problem, so generally a clinician can diagnose just based upon the history and physical exam. It can be confirmed by nasal endoscopy and audiology studies. Patients younger than 6 years of age may not complain of any ear problems at all, but rather have recurrent otitis media with effusion diagnosis. So we see that a lot in kids. So, and the reason that is because children have shorter, more horizontal tubes. They're immature, they're floppy, and they also have larger adenoids compared to adults. This places children more at risk for developing middle ear effusion, where fluid enters that middle ear space. As children grow, their faces elongate, and they generally grow out of this. Complications, so complications of untreated Eustachian tube dysfunction include conductive hearing loss. So a lot of times we'll recommend getting an audiogram, acute and chronic otitis media. This would be more infectious. Tympanic membrane perforation, otitis media with effusion. So this is where it's not infected, but there is middle ear fluid that is causing that hearing loss. And in rare cases, a cholesteatoma. Cholesteatoma is not cancerous, but it is a cyst, kind of like a ball of infection that can grow inside that middle ear space and cause permanent deconstructive hearing loss. Complications, normal middle ear versus middle ear effusion while using pneumatic otoscope. So a lot of ENT practitioners will use what's called pneumatic otoscope in order to evaluate for fluid inside that middle ear space. So here are two pictures, one being number 36, being a normal tympanic membrane or a normal eardrum. As you can see, the difference when you look at slide number 16, that is clearly evident that there is fluid or fluid level lines behind the tympanic membrane or eardrum. So when you use the pneumatic otoscope, it actually forces air inside the ear canal that will allow the eardrum to move. And if it doesn't move, then it helps us diagnose otitis media with middle ear effusion, which is fluid behind that middle ear. Now, having Eustachian tube dysfunction doesn't mean that you have middle ear effusion or fluid behind the middle ear or in the middle ear. What it does mean is that you are at risk for developing that. So how do we treat Eustachian tube dysfunction? Mainly, we need to know if it's either obstructive or patulous, and then treat accordingly. So if it is obstructive Eustachian tube dysfunction, that would mean that something is causing that, right? So a lot of times it would be viral or viruses or viral rhinosinusitis versus bacterial rhinosinusitis, allergic and non-allergic rhinitis, laryngeal-pharyngeal reflux, masses or lesions. And we'll talk about that a little more. So with viral rhinosinusitis or bacterial rhinosinusitis, we would use topical nasal steroids such as Flonase, intranasal or sinus rinses, and pain medication. Moderate to severe bacterial rhinosinusitis are typically treated with antibiotics. So once we can clear up that virus or that bacterial infection, a lot of times the Eustachian tube dysfunction will resolve. For allergic and non-allergic rhinitis, it would be trigger avoidance and allergy medications. Allergic rhinitis, trigger avoidance would be pets, dander, dust, avoiding all those things, and then treating their allergies a little more aggressively, so maybe nasal sprays, over-the-counter allergy medications, and so on. Non-allergic rhinitis may be vasomotor rhinitis, so starting them on ipratropium or a nasal spray to help calm that down. Laryngeal-pharyngeal reflux, that can cause obstructive Eustachian tube dysfunction. Those things would be lifestyle and dietary modifications. So whatever may trigger the acid reflux, which we see a lot of caffeine, chocolate, mints, spicy and acidic foods. So we would have the person or the patient avoid those things, those foods. Also, stop eating 3 hours prior to lying down. That is a modification that may help, and possibly even starting them on a PPI or a proton pump inhibitor, such as omeprazole, maybe a short course to see if that helps the acid reflux. And then mass or lesion. Sometimes we'll do what's called the endoscopic exam to look back there and rule out any mass or lesion that could be blocking that Eustachian tube opening. Sometimes adenoids are enlarged, or what we call hypertrophy of the adenoids, and an adenoidectomy may be indicated if they are enlarged, and of course removal of the nasopharyngeal mass if indicated. The The most common treatment that we tell people would be to do the modified Valsalva maneuver. How we instruct our patients is by telling them to hold their nose and their mouth closed, slowly and gently, elevating intranasal pressure with a sustained gentle nose blow. So by pinching your nose and gently blowing air through it, and simultaneously swallowing at the point of maximum pressure. So this actually activates the muscle that dilates the Eustachian tube. So getting those Eustachian tubes to open up and equalize that pressure inside the middle ear space. And sometimes this has to be done multiple times throughout the day. So treatment for patulous Eustachian tube. This is one that causes that otophony, the hearing one's own voice loudly. Sometimes this is most noticed during exercise. So we have runners that come in and say, every time I run, I feel like I can hear my own voice really loudly, or if I'm working out, but then it goes away once I'm done. So most importantly, we reassure patients that this is considered normal and recommend adequate pre- and post-workout hydration. So sometimes with, again, the patulous Eustachian tube dysfunction, the one where it remains open, some people who have experienced significant weight loss, they complain of this as well. But again, we would reassure them that this is normal and that weight gain is rarely effective in treating the condition. Sometimes smoking, so people who smoke sometimes complain of this. So we would encourage our patients to stop smoking. There is treatment that is surgical. Surgical management is reserved for severe symptoms who do not respond to medical management. Sometimes tympanostomy tubes are recommended, may provide symptomatic relief. However, up to 50% of patients experience symptom improvement after ear tube placement. So it's kind of reserved for those pretty severe cases. Treatment lacking supporting evidence. So there's little evidence to support the use of medications and other non-surgical treatments for isolated Eustachian tube dysfunction, but rather treat the underlying cause. So if there is no allergies, but we're treating their allergies, then it's likely not going to resolve the symptom, right? So if there's no acid reflux and we're treating the acid reflux, then it's likely not going to resolve the Eustachian tube dysfunction. Systemic pseudoephedrine, topical nasal decongestants, APRN, and systemic glucocorticoids have not been shown to improve obstructive Eustachian tube dysfunction. So a lot of people will try over-the-counter APRN. Some say it has helped, but most of the time it doesn't, and actually can cause what's called rebound congestion if used for longer than 3 to 5 days, and can actually worsen the symptoms. So we do not recommend that at all for the use to improve obstructive Eustachian tube dysfunction. Topical nasal steroids such as Flonase in the absence of sinonasal inflammation has failed to demonstrate benefit. And so topical steroids such as Flonase works by decreasing inflammation, right? So if there is no inflammation and we are prescribing or recommending a topical steroid to decrease the inflammation, then it will likely not improve their symptoms. So we really need to make sure of what the true cause or underlying problem is before we recommend any treatment. So in conclusion, Eustachian tube dysfunction can be rather bothersome, but generally not worrisome. So most of the time it will go away. It can be managed by your primary care provider. So definitely get that looked at, and they can absolutely manage that for you. However, if it's persistent, so we say greater than 6 weeks, referral to ENT is recommended for further evaluation and treatment. we just see this a lot. And we have things like the endoscopic exam that we could perform. We recommend audiograms and are able to help evaluate those. And so just a little more specific into the ear, nose, throat world or etiology there. So KSB Hospital ENT department would be happy to see anybody for this problem, or if you think you have this problem. We're located at Commerce Towers, 215 East 1st Street, Dixon, Illinois. And the phone number is 815-285-5603. So I hope this helps. If anybody has any questions or concerns, feel free to call, and we'd be happy to evaluate and talk to you guys about this. So have a great day.